node will not respond to atropine. Now, do you see why sometimes some rhythms might respond to atropine and sometimes it might not respond to atropine? Yes. Okay, that's the reason why. So some rhythms may be refractory to atropine and it might warrant you to do something more, isn't it? So what is this more that you can do?
Other medications.
Yes.
That you can go for.
Mm-hmm.
Or you can go for a device.
For a device.
Yeah, so for medications,
Uh-huh.
you can do adrenaline,
Noradrenaline?
Yes.
Uh-huh.
To 10 micrograms.
Uh-huh.
This is an infusion.
Uh-huh.
IV.
Uh-huh.
You can also do.
Wait, stop there. So, he's talking about noradrenaline, 2 to 10, what? Mics? Per? Infusion? Now you get where I was at. Sindio? We are lost. A bit. We are not so lost, but we are lost kidogo. Now let's begin with the drug. The 2 to 10 is okay, but what drug should we give? The 2 to 10 is okay, but what drug should we give? Epinephrine. Not norepinephrine. It's epinephrine. 2 to 10, what? Micrograms per what? Yeah, it is an infusion. But what? Per minute. Per minute. Are we together? It is an infusion, yes, I agree. But it's epinephrine, 2 to 10 micrograms per minute. Now remember, this is an infusion. There are instances in SCLS where you will give epinephrine as a bolus. So you have to know, is this an infusion or is it a bolus? Are we together? Okay. It's over an extended period because remember, the management that we are teaching you today, okay, it doesn't really make you small cardiologists. True. Even the ECG that we are teaching you doesn't really make you a cardiologist. It doesn't really mean that you know everything about the heart. The management we are teaching you is transitionary. Are we together? You're only keeping this patient alive so that they can be able to get to definitive management. Are we together? So now, to her question, how long? Should be as long as when the cardiologist now arrives and inserts a permanent pacemaker. Okay? So if you're treating this patient who is already on epinephrine infusion, I do not expect you in ICU to have this patient for the next 1 week, 2 weeks. On epinephrine, you're just changing epi all the time, epi, CT management, on epi infusion. What are you doing? Have you made a call? Are you referring this patient? Because they will not walk around with an infusion pump of epinephrine for the rest of their lives. They need definitive management. Are we together? Okay. So that is epi. What other drug can we give? Dopamine. Today is Wednesday. Today is Wednesday. Not Sunday. Okay. You get what I'm saying? Mnaimba sana. So dopamine. Gapi. How much of dopamine are we giving? There's somebody who is hiding and I want to hear her say, are you Joyce? Jacqueline, nipatie dopamine infusion. How much are we giving? Uko sure na dose. Okay. Your neighbor, how much of dopamine are we giving? Your neighbor to the right? How much of dopamine are we giving? You're not sure? Neighbor to the left? Yeah, I'm trying to prove a point that, chorus answers, some of us might miss because the rest are singing along. Okay? So you can sing, but then somebody might be singing bass and we are singing alto. Sindio? So they are really lost. So please, let's own our answers. So how much of dopamine are you giving? How much? 1 to 20? 5 to 20? Micrograms? Per kg? Per minute. Very good. Dopamine? 5 to 20 micrograms per kg per minute. Now remember, 1 milligram is equals to 1,000 micrograms. So even as you're converting, some of these drugs will come in milligrams. Sindio? So you need to know how to convert milligrams to micrograms. 1 milligram is equals to 1,000 micrograms. So we're done with the drugs for second line management of bradycardia. But there's still one more thing that we can do for second line.
So it's either or
Yes. Yes. What other thing can we do? Transcutaneous pacing. Yes. Now remember, all these three treatment modalities are second line management of bradycardia. TCP, dopamine, and epinephrine. And they can all be used independently to manage bradycardia. Are we together? So you can use TCP alone, you can use dopamine alone, and you can use epinephrine alone. Now, in case you want to combine, you can only combine TCP with either of the two catecholamines. Are we together? You can use TCP in conjunction with dopamine, or you can use TCP in conjunction with epinephrine. But according to the guidelines that we have, you can never use dopamine and epinephrine at the same time for bradycardia management. Okay? So you can never use dopamine and epinephrine at the same time for brady management. Are we together? But you can use you can use TCP with dopamine or TCP with epinephrine, or use either of the three alone to manage bradycardia. After your atropine works? Yeah, it works.
and then we just
Yeah, it works.
we don't have follow-up.
Not really, you don't have follow-up. If it works, then I would ask for a cardio review to find out what caused the brady. Is it something we can help in the future? Do we need do we need a permanent pacemaker? Yeah. Okay. Okay. Now very quickly, let's go to the individual rhythms. Are we okay with management? Okay, now for TCP, don't worry about it. We will demonstrate to you how TCP is done in the skill station. Okay. We'll teach you how to set the defibrillator to pacing mode and the different settings for pacing. Are we together? So we have to set the mode, we have to set the rate, and we have to set the amplitude, the output. Okay? On top of that, after you have paced your patient, then you have to assess whether there is capture. Okay, we will teach you how to do all this. Now, capture is basically, are you really pacing the patient appropriately? So in case you have set, you want a rate of 70, are you really achieving the 70? If you're achieving the 70, then you're having capture. Are we together? But if you're not really achieving the rate that you have set, then you're not achieving capture. Are we together? Okay.
What's the difference between electrical
The difference between electrical and mechanical capture. Now, electrical capture is basically what the machine is doing. Okay? It's discharging impulses. Okay? And once it has discharged the impulses, are these impulses being transmitted to the heart? And are they achieving the effect that you want in terms of raising the heart rate? Okay? Now, mechanical capture is now the pulse of the patient. Okay? Where you have to assess your patient. And it will happen to you many times during this course of this training, where you will look at someone, manage the monitor, but fail to assess the patient. It happens. So mechanical capture is basically the patient. Are you having a pulse rate of 70? The monitor is telling you, yes, we are achieving a pulse rate of 70. But physically on the patient, when you are assessing the carotid artery, do you have 70? Because the monitor might be telling you we are having 70, but on the patient, you're probably having 60, 65, and you have to do something to ensure that you're in tandem with what the monitor is telling you. Are we together? Okay. So let's look at the individual rhythms. So the rhythms that you will tackle in bradycardia 1 is a sinus. Bradycardia. So from the word sinus, what's the origin? Learning has taken place. SA node, isn't it? So it means you'll have a normal P wave, isn't it? Smooth, upright and rounded, isn't it? Yes. The PR interval will be normal. QRS will be less than 3 small boxes. There will be no ST segment elevation. You'll have a T wave. But the rate is below 60. So you'll essentially have everything normal apart from the rate. Number 2, you'll have your blocks, your AV blocks. And in the AV blocks, you have type 1, type 2, which has 2 categories in terms of Mobitz 1 and Mobitz 2. And then finally, you'll have your 3rd degree AV block, also called complete block. Okay? Now, let's look at them. So let's look at 1st degree block. 1st degree block. What are the characteristics of 1st degree block? From the class. Moses, talk to me. Can pass. Your neighbor is a doctor. Normal P wave, yes. Variable PR interval, okay. Okay, there is no drop. There is no drop. Okay. Now, in 1st degree AV block, thank you, we have a delay in impulse propagation. What? A delay, but never a block. Are we together? So all the impulses coming from the SA node are actually transmitted to the ventricles. Are we together? However, due to that delay, you'll have the PR interval being longer than normal, okay? But this prolongation is constant. Are we together? So it's not variable. It's what? It's constant. And every P wave will be followed by a QRS. Are we together? Okay. Let's go to second degree block. Now in second degree, we have two things happening. We have a delay, and also sometimes the impulses are blocked from reaching the ventricles. Are we together? Now second degree, we have type 1, also called Mobitz 1, also called non-Wenkbach. And we also have type 2, also called Mobitz 2 or Wenkbach, if you want to sound technical. Okay, so let's look at the characteristics of type 1. Now, type 1, number 1, do you have P waves? Are they normal? They are normal because they are coming from the SA node. But what happens to your PR interval? I like how I'm seeing this. Yes, so the hands know better than the mouth. Isn't it? So there is progressive prolongation of the PR interval. If you want to remember right there, long, longer, longest. Isn't it? Which eventually leads to a drop in QRS. So on the ECG, you will see a P wave, but it does not have a QRS. Now, the drop in QRS is predictable. It's predictable. What do I mean? In the morning, we talked about a normal PR interval having 3 to 5 small boxes. That's what we said, isn't it? So, if it is prolonged, it means it's more than 5 small boxes. So, in this case, you would have 6 small boxes, 7, 8, 9, then a P wave without a QRS. And then it resumes at 6, 7, 8, 9, then a P wave without a, then when it resumes at 6, 7, 8. So you can almost predict that if I count 9 small boxes, the following, cardiac cycle will have a P wave without a QRS. So it's actually predictable. Okay? Let's look at type 2. Type 2. Do we have P waves? We do, isn't it?
Yes.
Okay. Are they normal?
Yes.
They are normal. Is it regular or irregular? Is it regular or irregular? Regular. Write regular and put a question mark there. Then I'll tell you why. Put a question mark there. Okay. PR interval can either be normal or prolonged. The PR interval can either be normal or prolonged. We have drops in QRS, which are random. So the drop in QRS is actually random. You cannot predict where it will occur. But the one thing you know is that it will definitely happen. But you cannot predict where it will happen. So now, is it regular or irregular? It's irregular. Because where you'll have a drop in QRS, then that's where the irregularity will occur. Can we move? Now, first degree, is it regular or irregular? It's very regular, isn't it? Second degree, type 1? Irregular, isn't it? Irregular. She's talking about irregularly irregular. Fine. Sawa. Irregularly regular. Ah, yeah, sawa. No problem. I like that. Let's go to third degree. Now, third degree, we also called it complete block, isn't it? Do we have P waves? We do. Do we have QRSs? Do we have QRSs?
Yes.
Is it regular or irregular? Is it regular or irregular? How many say it's regular? Regular. It is regular. How many say it's irregular? How many are watermelons? Sawa. So you want to set us straight, isn't it? Now, third degree is regular. It is regular. It is regular. I'll tell you why. Now, in third degree, you have a complete block, what we call atrioventricular dissociation. So the atrias and ventricles are dissociated. Now remember, in normal physiology, the atrias and ventricles work together to produce a cardiac output. So the atrias contract first, and then the ventricles contract next, then we have a cardiac output, isn't it? Now in third degree, that association is non-existent. That's why we are calling it a dissociation. Are we together? Now, so in third degree, the property of the myocytes that we refer to as automaticity comes in. Okay? It comes in. So the atrias will be paced by the sinoatrial node. The SA node is working. It has no problem. The problem is in the propagation of impulses. Are we together? Where we have a complete block. So the ventricles wait for this impulse and realize it's never going to do what? It's never going to come. So what do they decide? They decide to have their own pacemaker, which begins to fire. Were you told about the Purkinje fibers? Yes. Were you told that they can actually pace the heart? At what rate? 20 to 40, isn't it? So they kick in. And they begin to pace the ventricles. So the ventricles have their own pacemaker. The atrias have their own pacemaker. And the ventricles have their own pacemaker. So is it regular or irregular? It is regular because the ventricles which produce the QRSs will have their own pacemaker which will be firing at regular intervals. So it is regular. So you'll have a regular atrial rhythm and a regular ventricular rhythm. But the association between the atrias and the ventricles will not be there. So you'll have instances where you'll have a P wave followed by a QRS, instances where you'll have a QRS coming in front of a P wave, instances where you'll have a P wave without a QRS because the association is not there. Are we together? Any question? I'm done with Brady. Any question? Yes. I wanted you to answer that one. Morbits 2, is it regular or irregular?
Irregular.
Now you know.
On the clinical aspect,
Yes.
in this complete block, when you listen to the stethoscope, or when you palpate the pulse,
You'll feel it's definitely bradycardic. It's definitely bradycardic.
will it be a regular constant?
It will not. Honestly, I've never had a third degree block, so I can't speak from a point of experience. But what I do know is that the hemodynamic stability of this patient is compromised severely. So you probably have very low BPs. Probably you'll have altered mental status, which will then prompt you to, take a history. Probably you'll have, either of the 5 symptoms, or if not all of the 5 symptoms. Then when you connect a cardiac monitor, then it confirms your diagnosis of third degree block. Okay? Yes. You had a question? It's constant. So it's constant. It can be normal or constantly prolonged. Are we together? If it's long, it's constantly long. It does not progressively prolong. Okay? Okay. Are we okay? Are we okay? Okay. So can we deal with Turkey? Okay, let's have a 5 minutes break. Let's have a 5 minutes break. Come again? Oh, you actually determine both the atrial and ventricular rate. That's how you know it's. So you actually count the number of P waves, then you number of QRSs. So you'll have two rates for the ventricles and the atrias. Yeah. Oh, the video can be replayed again. Hapo kwa rhythms. No. Yes, you can get access to them, but not personal copy. On the e-learning platform, Zico. You'll have all these videos on the e-learning platform, but you can't download them. You can't have them. You can't have them. No. So it's just your internet, your data. So all these videos that we are showing you are on your e-learning platform, where you did your pretest. Where you did your pretest, we have all these videos. So in case the video was too fast or too slow, or there's something you didn't get, you can always watch and rewatch over and over again until you're okay. Okay? Just sina access ya ile laptop.
Sorry?
Sina access ya ile laptop. Hi, you guys. Hey. Ah, come on. So. I didn't want to get into Turkey. So, okay. Nice photo. Well, bwana. Well. That you don't take time. A whole hour. I think so. No. So you can place it here. Sawa. Tena nikuangalie sound. Sawa.
You are through? You're not? From where? So how is it going so far? Okay, let's move on. So we want to do tachycardias. And having done the rhythms and having done bradycardia, now the tachycardia is going to be okay. So it's tachycardia, so we shall go with that speed. So in the next 20 minutes, we should be through with this thing. Yeah, it's a turkey. Should we go with a slow pace? No. We are doing tachycardia. So I will go very fast, indeed very fast. Now the objectives for the class shall be: 1, we want to define what tachycardias are. Once we define tachycardias, we classify tachycardias. And then we are going to, this is still part of classification, then we'll look at treatment for tachycardias and probably why are we concerned with a patient who is tachycardic. So why are we concerned? So therefore, let's do with the number 1. So what is tachycardia? What is it? A heart rate? Beats per minute. That's all. In a resting state. Please don't forget that. Or at rest. So for us to talk about tachycardia, that is we need to be worried about is a heart rate above 100 at rest. So if you've done an exercise or you're about to do exam on Friday, all of us will be where? Should we be worried? Is this something to worry us? Why? No, we should not be worried about that. So yes, we shall be having tachycardia, but it is nothing that it will make us be concerned. Now let's talk about the classification of tachycardias. So we have defined what it is. We classify tachycardias into 2 broad categories. Number 1, according to the QRS complex. So we classify tachycardias according to the QRS complex. And that is number 1 classification. So this is your QRS complex. And we say the QRS can either be, and now you know what we talked about in the morning, narrow or wide QRS complex. So that is the first classification. Now once you classify on the QRS complex and you look at the rhythm can either be, yes, so the rhythm can either be regular or irregular. At the same time here, we can also have a regular rhythm or irregular rhythm. Now that is class 1 or classification 1. Now I want us to give me tachycardias that have a narrow QRS complex and they are regular rhythms. So which ones are they? Yes? Okay, sinus tachy. Who else? Supraventricular tachycardia. Who else? We were in the class of the morning, so now this one is a revision. Who else is the second rhythm? Atrial flutter, very good. You guys were in class. Do we have another person here? Atrial fibrillation is where? Yes, so we are talking about narrow QRS complex, irregular rhythms, but they are tachycardic. Are you through? Now let's talk about examples of narrow tachycardias, which are irregular. So they are which ones? So atrial fibrillation. Keep going. Atrial flutter. Keep going. What did we say in the morning? Refer to your notes in the morning. And I actually explained and said, they are regular. And 1% is irregular. We actually discussed this in the morning. Multifocal atrial tachycardias are also here. Multifocal atrial tachycardias. Then, those are the rhythms. Now, let's talk about the tachycardias that are having a wide QRS complex and regular rhythms. So here we have who? Yeah, so monomorphic ventricular tachycardia. It's only one. Then tachycardias that have a wide QRS complex and irregular. So we have polymorphic VTAC. Any other one? Then we have a VF. Yes, you're saying the polymorphic was what? Yeah, but it's still irregular rhythm. It is still irregular rhythm, so yes. We said mostly of them they are irregular. When you fight an irregular one, management is still as a regular rhythm. So we classify it still here. It's just a trigger. And when the trigger is not controlled, it now becomes just your normal SVT, just like that. So that is classification number one. We did that one in the morning, isn't it? And you can now see the rhythms in your mind and actually draw them now. Everyone can draw sinus tachycardia, atrial flutter, AFib, you can draw monomorphic VTAC, you can do everything here now. Is there anyone that you cannot? Classification number two. We classify the patient as based on, so this one, don't leave some space down there. Leave some space down there. Now the classification number two, we classify according to the patient's hemodynamics. So according to hemodynamics of the patient. Now hemodynamics, we are talking about what? Patient's presentation. How does the patient present? And here we classify either as stable type patient now or unstable. So this is classification based on the hemodynamics. Now when we say a patient is stable, this is what they have. So for you to say the patient is stable, number one, they have a fast heart rate above how many? 100 beats per minute. And less than how many beats? Less than 150. So let's say 140, about up to 140. So these patients have a fast heart rate above 100 and below 140. Number two, what else do they have? They have no associated symptoms. So that patient, despite the fact that they have a fast heart rate, they have no other symptoms. So that patient will be said to be stable but with tachycardia. Now let's go to the other patient. An unstable patient has fast heart rate above how much? Very good, above 150, but this is what your book says. The patient may present otherwise. So don't say the book says 150, patient has 145, and is very unstable when you say, no, you cannot be unstable here. The book says 150. So you will manage the patient as they present. Is that okay? Though they have fast heart rate above 150. Number two, what do they have? So they have associated symptoms. So they have associated symptoms. And number three, what do they have? Haggai. They have what? So the symptoms they have is as a result of the tachycardia. Symptoms are due to the fast heart rate, not something else making the patient tachycardic. So this point is very important for your classification. You're getting? So they have a fast heart rate, yes. They have other symptoms, but the symptoms they have are as a result of what? This fast heart rate. Not some other problem making the patient tachycardic. You're getting? Yeah, no. So, for instance, let me give you a small a scenario or case. If a patient comes to you now, you told me you also do trauma and orthopedics. So a patient has been involved in RTA along the, which road is this now? Southern bypass. And they got a femoral fracture or a pelvic fracture, and they lose 2.5 liters of blood. So when the patient comes into you, they have a BP of 70/30. The pulse rate is at 160. SpO2s are at 80%. RR is 24. Any other? So this is what you have. Classify your patient. Classify your patient. Unstable, eh? Unstable what? Unstable hypertensive. What? The patient hypertensive shock. What is this classification? The patient is already in shock. Which shock is this? Hypovolemic shock, eh? And what is the cause of our instability here? So bleeding, eh? So we cannot say this patient has unstable tachycardia as much as the heart rate is a compensation of the fluid, of the blood loss. So we cannot say this patient, we are treating the tachycardia. No, the tachycardia is not a problem. It's actually a compensating mechanism to try to make sure there is blood in every part that is necessary. They are very vital organs. So this patient, you cannot say they have unstable tachycardia. But the patient is unstable, we agree. They have hypovolemic shock. Now let's talk here now. So why do you think this patient will get the symptoms? So if I have a heart rate of 150, 160, what are the symptoms first? What are the symptoms first? So they will be feeling their heartbeat. So conscious awareness of a heartbeat, that is palpitations. Ideally, you are not supposed to be feeling your heartbeat. What else are they going to be having? So they will be restless, agitated. So the patient does not rest. You tell the patient, stay here. You tell the doctor something is not okay. What else are they having? Hypotension. What else? Oh. Yes? So they will have altered mentation, altered mental status. They may be confused. They may be combative. They may be restless. So they are agitated and confused. What else? Thank you. So they have signs and symptoms of shock. So they have cold, clammy extremities. Patient may be diaphoretic. Patient may be also what? You're not able to palpate the peripheral pulses. Yes. They also have the signs of acute heart failure. And this patient also have ischemic chest pain. Because now, why are they getting the symptoms? Why? What is physiology about this? Ineffective blood pumping. Do we have a problem with our pumping?
Pure blood, because the heart is pumping too fast, so the ejection function
Is the conductivity an issue here? Do you have a problem with the conductivity? What is our problem here? Reduced perfusion. But why are we getting reduced perfusion? That's the question. Because of the tachycardia. What's happening with the heart rate?
You're not getting enough time to contraction and filling.
Yes, that's the point. So we do not have filling time. Remember, we are pumping too fast. So there is no filling time. And therefore, that means what? If the ventricles don't fill and is beating too fast, then whatever has come is what is pumped out. And therefore, because of that, we are going to be getting what? Inadequate cardiac output. And as a result of that, now that is why all these symptoms and signs now appear. So is inadequate cardiac output as a result of reduced filling time. Because the faster the rate, the shorter the PR interval. And remember, the PR interval was the time ventricles are filling. So there is no time for filling. And therefore, that is why we have such symptoms exhibited in our patient. So therefore now, what are we supposed to do now? So this patient has symptoms. So we've classified number 1, based on the QRS complex. Now we are classifying based on hemodynamics. So we come over to our next point, regular, then look at your patient. Now classify the last one. Is your patient stable or unstable? You come here also classify the patient again. Is your patient stable or unstable? Then on the same here, is your patient stable or unstable? Okay, what about here? So that is classification now. Here, so these are all unstable. So that is classification now that we're going to be having in your tachycardia. And this brings us to the end of tachycardia teaching. Any questions? So we are through. Where's the medications? And that is why what you do in your place of work. So we said we are going to be with this speed. And we have finished tachycardias. We've not done what? No. Yes. You want medications in this class? Okay. There was another question this side. Okay, so once we classify the patient, management is too easy. So now, your management here will be, you cannot manage a patient you have not classified. Please get that as the first thing. Every time the patient comes into you, classify your patient. If they have a cardiac issue, if it's a cardiac, classify 1 based on the QRS complex and based on patient's stability. So that now you know I'm going to be using a pathway for a stable patient or a pathway for unstable patient. Because a stable patient is managed different from unstable. So that should be clear. Don't manage a patient without classification. Otherwise, we are going to fail you. So the first thing is classify your patient. That's why we have classified our patient. So you will be able to tell me, I have a narrow QRS complex. The rhythm is regular. My patient is stable. When you tell me that, now you can actually be able to isolate. Is it SVT? Is it a sinus tachycardia? Is it what? You can be able to isolate that. And by that doing, you'll be able to manage your patient very correctly. So let's manage stable tachycardias. Stable tachycardia. We'll start with number 1. Sinus tachy. Sinus tachy. So let's manage then. Now, since you you are shouting, let's manage the patient. Now, this is a sinus tachycardia. Do you want me to repeat again all the properties? Yeah? We did that one in our class 1. Now we are in class 2. So now that's why we were promoted to class 2. So you don't go back and say we are in class 2, let's go to class 1. Now, so when you talk about sinus tachycardias, is this patient going to be unstable in any way? So all sinus tachycardias will be stable. You will not get a sinus tachycardia with a patient who has a heart rate above 140. It's not possible. So they are stable patients. So what will be the first thing? What is causing the tachycardia? This patient tachycardia is because of external stress. So they have external stressors. So sinus tachycardia basically is because of external stressor, like a patient has fever, patient has pain, patient is anxious, patient has what else? Dehydration. Yeah, all such will cause sinus tachycardia. So what will be your plan of management? So reassure the patient, all is well, then find out the cause of the tachycardia and correct the cause, and the patient will be okay. So that is finished. Any question on sinus tachy? Reassure, find out the cause of the tachy, and treat the cause. If it is on Friday when you're about to do your exam, what is the cause of tachy? So we give you the exam, and we finish with you. Is that the case? Or that? Namna gani? If the problem is tachy, is exam, we give you the exam. Once we give you the exam, you are okay, you are treated. We will not admit you in ICU for 24 months. No. Let's manage SVT stable. But before we do that, maybe I see whether you're able to identify a stable. We can look at a small scenario here. So a paramedic calls from an ambulance scene and is calling Kikuyu Hospital with a patient who is a 47-year-old lady with a sudden complaints of palpitations, no chest pains, and no dyspnea. BP is 150/80. The heart rate is 160 and regular. Alert, oriented, the respiratory rate is 20 and lungs are clear. Paramedics request for permission to do synchronized electrical cardioversion on this patient. So he's asking you as a doctor at Kikuyu, what do you tell? This is a rhythm that they have. What do you tell the paramedic? No what? No cardioversion. Why? So is the patient stable? Yes. Do we agree? Yes. Okay, so what are we going to tell the paramedic to do? Reassure the patient? No. This is not the time for reassurance now. So what are we are telling the patient, the paramedic, do not do synchronous cardioversion. Yes, I agree. But he's asking you, then what do I do? Because the patient is looking for you. You told the patient, we will help you, we'll take care of you today. Now he's looking from you. So what do we tell the patient to do? Yes, so we do vago maneuver. So stable SVT, first line treatment is now vago maneuvers. Also called mechanical cardioversion. So vago maneuvers. And we know now why we are doing vago maneuvers. Should I explain again a second time? Not to waste. But we say the vagus nerve innervates up to the level of AV node. Okay? Our patient has a narrow and regular tachycardia. Is coming. Where is it coming from now, this one? Just above the AV node. Okay? So if we do vago maneuvers, what we are going to be doing is we are activating the baroreceptors, the ones at the carotid sinus or at the arc of aorta, which will now activate the parasympathetic nerve, and that will slow our heart rate. So this rate will be slowed by that. So that is why we're doing vagal maneuvers. What are the examples of vagal maneuvers? So the cough reflex, you can do cough. Carotid massage. Gag reflex. They can blow a syringe, a straw. Yeah, Valsalva maneuver. Diving reflex. Those are okay. Diving is like person who is getting into the water. The diving reflex. When you go to shower now and the water is very cold, what happens when the water comes? So that feeling activates Vegas. Patients who go to the toilet and you realize the patient has got a cardiac arrest in the toilet. What happened? The elderly patient, they already have bradycardias. They are on beta blockers. They go to the toilet. Valsalva maneuver. What happens?